for your viewing and your, not entertainment, but education. So our patient has a herniated extruded disc at L5S1 on the right side. He has severe pain radiating down his leg into the right leg. We call that sciatic pain. And he's tried conservative treatment, which hasn't worked. At this point, we're going to be performing surgery. There's different surgical options for a patient with a herniated disc, depending on how big the herniation is and whether it's bilateral or unilateral. Bilateral means both sides, unilateral means one side. Whether there's instability associated with the herniation or it's just nerve compression. So there is a multitude of different surgical options. Some are better than others. In this case, the patient opted for what I believe is the absolute best of the best for disc herniation, and that is the Deuk laser disc repair, which is done at the Deuk Spine Institute here in Melbourne, Florida. It's essentially a modification of endoscopic transforaminal surgery. Whoops, I'm on the other side, I apologize. Just getting my steps in. Excuse me. What are we doing here?
Camera issue.
All right, what kind of camera issue are we having? Well, we've got somebody else here who needs to learn how to take care of it besides you. So I want to make sure. So just tell us what you're doing. You're doing a restart, a reboot. You're unplugging the camera from that box before it fires up. It's kind of like a computer, right? You got to remove all the peripherals before it reboots, otherwise it gets caught up. So there's a problem with it. You're just going to switch the whole tower out? Well, you need to deal with it later. All right. So you don't want to just, yeah, I see. You don't want to just change the camera box itself. All right, so for those of you listening, sir, we're going to switch out the endoscopy tower. It's going to take about 3 minutes to 5 minutes to do that. So I'm going to talk to you for a minute while we're doing that. We don't need the scope right now, but I want to make sure the other one is working before we proceed. We have 2 towers. So if you could, are you comfortable?
Yeah.
So I was just telling our audience, because we broadcast all of our surgeries live, they don't know who you are. All they can see is a little patch of your back here. And they all look the same. And so I was telling our audience, that's my hand on your back, by the way. I'm not getting fresh with you. I'm just resting it. But I was telling them how this is live spine surgery. So one of the things about live spine surgery is, hey, we have issues we deal with in here, and you get to see how we deal with them. So that's kind of the what I wanted to create was a reality TV show, so to speak, of spine surgery for the world to watch. Because, you know, there's no drama in the ORs of people, you know, cheating on each other and kissing and fighting, yelling and screaming. The real drama is what happens when the equipment doesn't work. What happens when we don't have somebody show up on time. You know what I mean? So those are the real dramas that happen in real life in surgery. So I want people to be able to see the real dramas, not the fake stuff that TV produces. Right? So everybody gets to be participating with us as we change the tower to the other tower. Carl, we have 2 full towers, right?
The other one has a box too on the bottom.
Do we need to consider a 3rd tower?
The other one has the exact same box.
Yeah.
It's down below, it's not being used.
I think we should look for a 3rd tower. Would you do that? Show Luis how you do it. Because if we're going to get busier with LSI closing, which I expect we are getting busier, we may want to run 2 rooms. And Dr. Patel looks like he wants to do some of these procedures too. So, may not be a bad idea to get a 3rd tower. So Luis, Carl will show you how to search. So at this point, we're switching the towers out. We'll get the other box, camera box repaired. And it looks like this one's working. But I want to make 100% sure before we make any incision on the patient. So it's one of the things surgeons do is we don't start surgery unless everything is available in terms of equipment, instruments, supplies, drugs that we're going to need throughout the surgery. You don't want to make an incision, start the surgery, and then find out later on you can't finish it and do what you need to do because you don't have the right equipment or you don't have the right implants or instruments or medication to perform the surgery. Just so you know, that's a $12,000 scope you're holding. You break it. I mean, we're paying $5,000 right now just to repair one that I don't know what happened to it. So the best thing to do is to leave it to the experts.
That one went out before in procedure.
What?
That one we set off, it went out during procedure.
Yeah, but we have lots of scopes. I'm not worried about scope, except to pay for it. I'm worried about the equipment that we only have one or two of that fails. Is this going to work or not?
Yeah,
All right, we're good. So then I'm going to move forward at this point. Sir?
Yeah.
This is Dr. Deuk Majin, and we're going to get started.
Okay.
So the first thing I'm going to do is numb you up with some numbing medicine under your skin, okay?
Okay.
You're going to feel a little stick and burn when I do that. That's normal to feel that. Thank you. Don't be alarmed. Now, at some point, I'm going to put you to sleep, okay?
Sure.
And when I put you to sleep, you'll wake up afterwards, we'll be done. But right now, you got to be awake for the beginning.
Right. Okay.
All right, so that's my hand touching you, okay? So we're going to go ahead and get started here. I'm just going to give you a little pinch. And then you'll feel a stick and burn, okay? Now, if you feel uncomfortable during the surgery, I just need you to tell me. Just say, ouch,
Okay.
if you feel really uncomfortable. But it's important that you don't wiggle around and move. Moving makes a moving target for me. All right, 6 cc's injected of local. Jesus Christ. Could the problem be the camera, Carl? Well, let's try to get this working. Maybe the problem with the other box was the camera too. Maybe it's not a camera box problem. Maybe it's a camera problem, since we're having issues with the second one.
There's another camera on the field up there.
All right, so let's try the other camera. Huh?
The other camera, we took it out.
It's just, you took it off?
Well, it was here, we took it out, so it's off.
Again, real life surgery. Why is the scope light on? Luis, it should never be on like that, ever. Yep. When we're not using it, if you're not white balancing it, you turn it off. Otherwise, you can burn a hole in the drape because it's a very powerful. Plus, you just burn out the light bulb. Make sure Carl shows you how to change the light bulb on the endoscopy tower.
Yes, sir.
So we're back into a holding pattern, folks, for those of you watching, because we brought the new tower in and we plugged the camera in and it's doing some funny stuff. So we may have a camera issue rather than a tower issue. Anyway, while we're waiting, our patient is being patient with us. We appreciate that. Does the audience have any questions?
Not yet.
Careful with that camera. Don't bang it. So these are live surgeries, and that gives the audience an opportunity to ask questions to the team while we're operating. We have an anesthesiologist here. The anesthesiologist is monitoring the patient's airway, cardiovascular system, and administering sedation, as well as any other medication that need to be administered during surgery. We have a circulating nurse or two who help the team get supplies from the sterile processing department, document the surgery, document everything, get us medications. We also have, I have an assistant today, Dr. Patel, my partner, who's in here helping me. We have our laser tech who runs the laser machine. The laser machine itself is, I don't know how to explain. It's about as big as a dryer or washing machine. It's pretty big. It's on wheels. They bring it in every time we do surgery. It's already been calibrated and tested, so it's ready to go. We have our biomedical engineering evaluate each time it comes in and certify it. So the laser machine is here as well as a technician to run it. And I have my surgical technicians. You want a white balance on the white. Let me show you. The easiest way to do it is to pull it back a little bit and lift this up like this with your other hand. Grab it. There you go. A little higher. Right there. Just don't get the blue line. And push it. No, it's too close. What are you doing? Right there. Well, he's got a white balancer, Carl. Let's go.
Yeah.
So what does he do?
The button.
You didn't tell him.
The button on the side.
Sweet Jesus. Come on, guys.
There you go. Okay.
Wait. Look at that scope. Let me see that scope. Put that back on the white, please. What is that? Carl? Let's clean it. How are you going to clean it, Luis? Well, before you get all carried away, so have we decided what the problem is? Is this a camera box problem or a camera problem? Come on, Luis. Come on. Water, wipey. Okay. Now let's see if the lens is clear. If that brown thing is there. Show me. Looks better, right, Carl? Can you please instruct him? He's still standing there holding it like that.
Put it down.
Remember, he's a little baby that needs hand holding. Okay? Just like I was when I started being a neurosurgeon. Luis is smart enough to know not to do anything without first seeking advice. Okay, are we ready? So what do we determine then? It's not the camera box, it's the camera. Is that correct?
Yes.
So what I'd like to do when this case is over,
This wasn't clipped on all the way. Yeah, to the scope. And it was showing it off. You know what I mean?
that's possible.
When they
So,
put it on, they put it on
so Carl,
halfway.
that doesn't explain the first box not working, does it? Or does it?
No, the first box, that's a different issue.
All right, so there's,
two issues here.
so we just had the scope attached improperly
Yeah.
for one issue,
Yes.
which is easy to resolve.
Yes.
And the other is there's really legitimately a camera box problem.
Yes. And we have another box.
So you think the camera we had on the field a few minutes ago still works normally?
Yes.
So Luis, you're going to get to, after this procedure's over, work with him and test the boxes, test the cameras, and figure out what's wrong. All right. In the meantime, we're going to get started. All right, sir, we're going to get started, okay? We're ready to go. Yeah. Yes, that's why we have redundancies. But we will need, I do want you finding another tower. Okay? All right, so remember, if you feel discomfort, say ouch. And I'm going to, I always want a Raytech here. I'm going to give you more numbing medicine, all right?
Okay.
The most important thing is don't squirm around. Okay?
Okay.
Just say ouch and I'll stop and give you more medicine. All right, so this is the right side. Everybody's in agreement? And we're going to get started. L5S1. Num num. You need to figure it out, Carl. If you see him not doing it, you need to advise him. Don't do it for him, but just advise him. All right. Remember, if you feel uncomfortable, you let me know. So these should not be here. They should be there. Our patient is relatively thin. So we get all different shapes and sizes, and you know the trajectory for the needle changes a little bit depending on the body habitus of the patient, but our patient is very thin. And let's get an x-ray shot. That's it there. All right, so I'm too high up. I want to redirect further south. Shot. Let's go lateral. Once you get close enough to the facet joint, you want to switch to a lateral view. Now, I may get pinched here, right? So that's fine. But you always want to be careful because your back's not sterile. Why is this so high? Yeah, let's bring it down. All the way to the ground. It's all the way? Great. All right. So tube's in the way, Luis. That's the first thing you should notice. You see the tube there? Let Luis do it. I got to teach him. Okay? The most optimal place for this is going to be right there. It won't interfere front. It won't interfere side. It's perfect. Shot. All right, so we have a nice trajectory right to the L5S1 disc space. You can see the sacrum there. I mean, the x-ray picture is perfect. Our technician's doing an awesome job. So I just have to finish getting us there. Shot. A little bit high. I want to be a little bit lower than that. Shot. Sometimes you just have to change the bevel direction. Let's get an AP. So if I got real lucky on this first pass, if you count it as first pass, I guess it would be 1F because I did some micro adjustments. But if I'm lucky on the first pass, then we're going to be probably right at the mid-pedicular line. We're not. So we're too far lateral. So I need to redirect and go a little bit more medial. But we're awfully close, right, Badat? I mean, I think it's pretty darn close, but I would like to be a little bit more medial. Shot. All right, let's go with an AP lateral view. I apologize. That's actually really, really good right there. So if we're lined up with the disc, then I think that's a great place to enter. So how do you know where to enter as a surgeon? It's experience, trial, and error, really. That's what it comes down to. Are you comfortable?
Yeah.
You feel anything there?
Nothing yet.
Shot? All right. So we're right where that herniated disc is, okay? You're doing fantastic, by the way. I'll need a little bit more help from you in just a few minutes, but then I'll be able to put you to sleep. All right, so I'm not able to get in shot. I keep hitting the end plate. Yeah, I think Dr. Patel's right. We need to wag it a little bit because the end plate is not lined up properly. L5 superior end plate's lined up, but the S1 is not. So let's shot. So that's something you need to do automatically, okay? I don't know. We need to figure it out. A little more, Dr. Patel is saying. So I'm just a little too low in the foramen, which is fine. All right. You like that, Dr. Patel? Yeah. Dr. Patel is giving his approval by a nod. He's saying go south by about 1 inch. So we center up the L5S1 better on the x-ray picture. And you can bring the collimator and yeah, I mean, I would. There's a lot of wasted space. We're not trying to look at the gut. I wouldn't bring the shot. Let's just see where you are. Yeah, I think that's fine. Can you bring the top down and narrow it up? There's no reason to give too much radiation. All right, shot. So I'm going to try to enter the foramen a little bit higher. Are you comfortable? Shot. Shot. That might work right there. Shot. Give me an AP, please. Now, do you have back pain normally?
Normally, no. Not a
Just your leg?
just the leg right now.
But have you had back pain before?
Yes, in the past.
And I know the answer already. It's a rhetorical question. But I'm getting you to think about your back pain for just a moment. Because I'm going to want to see if we're in the right spot. Okay? Are you comfortable, sir?
Yes.
No pain?
No. Back pain has always been in the lower back.
Yeah, your lower back is where the back pain is?
Ouch.
All right. Did everybody see him move off the table? Sorry about that, sir. But I had to test. Let's go with a lateral. Was that where you get your back pain typically?
Yeah.
How bad was that on a scale of 1 to 10?
That was 10.
That was a 10. So for those of you paying attention, you notice when I injected the dye, I did not tell the patient I was injecting. I just got him thinking about his old back pain that he had. We need to, there's a massive tear, huh, Patel? Yeah, I shouldn't even have to tell you this, but that has to be centered. So you should just automatically do it without me stopping what I'm doing to tell you. So we know that I'll give you a minute. No, you've done a really good job, so I'm going to be very patient with you. So we know that from that test that we injected the disc that's causing his back pain, because he literally almost came off the table. And you felt your typical back pain that you get when you get it?
Yes.
Yep, we call that concordant. So the nurse should be documenting a concordant, L5S1 concordant 10 over 10. With the, and we call that procedure, are you guys ready? We call that are the end plates lined up all the way? Let's see what we got there. Shot? Yeah, that's good. We call that procedure a discogram, but it has a specific name. It's called a evocative discogram. Now, normally we'll see more dye in the disc, but his annular tear, where his herniation is so massive that the dye just leaked right out into the epidural space behind the disc, and you can actually see. Luis, you know how much on the pig to use, right? To mix this up?
The nurse? No.
He needs to know
Okay.
everything.
Okay.
Yeah, and yeah, we're gonna go to sleep, okay? Can you count to 100 by ones, please? Start at 1.
1, 2,
Nice. Keep going.
4, 5,
I'm gonna talk while you're counting, okay?
7,
So, folks, you can see the needle coming into the disc. There's the guide wire, and you see all the black behind the vertebral body. That's the dye that leaked out of the disc space through the tear in the back where the herniation is that I'm going to fix right now. It leaked out, and now it's all around the nerve roots and inside the epidural space. Keep going. You're doing fantastic. So once I get the guide wire in, I know there's a question, Zach. Just give me a second. I can take this needle out, leave the guide wire in. You remember, you got to hold the guide wire, otherwise it'll come out. Now, once your needle's out, you want to check. No, you don't need to hold it. Shot, that's it? Okay, so we can see the guide wire is still in good position. And we're ready to go in and do our incision. The patient's asleep. He's no longer counting, so I know he's out. Now, we use propofol sedation. It's the best you can do. It's the best you can do for your patient is propofol. And it's also pretty expensive, but we don't care. You know, we're not trying to save the insurance company money. They have plenty of money. They don't need us to help them, despite everyone thinking that they've convinced everybody that they're struggling, these health insurance companies. I guess if you call $10 billion a year profit struggling, I mean, I feel bad for them in that case if that is struggling. My definition of struggling is different than their definition of struggling, though. But they've got everyone believing that they're struggling. And that's why they're denying medical care to people, denying authorizing surgeries, denying authorizing treatments, denying authorizing use of medications that are better for patients, They have formularies. Formularies are really nothing more than a way for them to negotiate better, lower payments to the pharmaceutical companies, which of course the pharmaceutical companies are making too much money themselves. But the wool has been pulled over America's eyes, and the American people are being misled by big businesses like the insurance companies and pharmacy. All right, we're trying to advance the dilator through the annular tear. It's actually going pretty easily. Once I get it into the annulus, then I'm going to take the guide wire out. Shot. And I feel like we're right there, so I'm going to take the guide wire out, hand it off, and I'm going to hold this thing steady and advance it. Shot. Very nicely done. And I'm going to take a question in just a minute, but let me get this cannula in first, and then I'll take some questions, okay? So now, for those of you watching, the whole surgery is done through this metal tube. That's how amazing this surgery is, and it's done without removing any bone from the spine. We literally just make a cut that's tiny, the smallest surgical incision you can make, 7 millimeters. In the neck we do 4 millimeters, so I guess that's really the smallest, but that's 7 millimeters is the smallest for lumbar. Nobody else has an incision this small besides the Deuk laser disc repair and other surgeons that use the Wolf endoscopic system. So dilator's in, and now I have a pathway for my tube. And by the way, this is like I always call it the McDonald's shake straw, but it's probably about the size of any kind of a large straw whenever you go to a convenience store and buy a soda or a Slurpee. That's pretty much the whole surgery is being done through that skinny little straw. All right, Zach, we'll take the first question.
So we have a viewer that says, I have a tear at my L5 disc. I have constant sciatic pain. I previously had a discectomy at that area, and I've been off my spinal cord stimulator. I'm wondering if a fusion would be a good option or what the best option would be.
Yeah, so we have a viewer who's saying, I've got an annular tear with a small herniation. I have a spinal cord stimulator, I believe. The stimulator's been off. Would this surgery be a good surgery? 100% yes, that's it. You're in, go ahead and take the dilator out, but hold your tube in position so it doesn't come out. Yeah, this is going to be the best surgery in the world you can do, right here, hands down. And just so you know, I don't say that because I do this surgery. I say that because I do all spine surgeries. I can do anything in the spine. That's from my training. You know, so some people think, oh, the surgeon just says it's the best surgery because they do it. No, I do artificial discs. I can do fusions. I can do osteotomies, microdiscectomies. I mean, you name it, I've done it and can do it. The reason, this is, look, see that? The reason we do this surgery and not the others, even though I could do the others, is because this truly is the least invasive, the most successful, and the lowest risk for the patient to be injured from a complication. All right. Thank you, Dr. Patel. So, yeah, I really do believe that given what I'm hearing from you, that you have the herniation, the annular tear, the stimulator. You know, I'm going to digress for a second. I'm not saying this is the case for you, sir, or lady, whoever is asking the question. I don't know who you are. But the truth is that spinal cord stimulators are put in way too often when they're not needed, when they shouldn't be put in. And unfortunately, I mean, we do put spinal cord stimulators in at Deuk Spine as well, but we reserve them for people who are really, really, really bad surgical candidates to have a real surgery to fix their problem because of either a medical issue or something else. But yeah, definitely spinal cord stimulators are over put in because they're put in mostly by pain management docs, and that's really the only thing the pain management doc can do that's surgical. And so they're basically having patients do a procedure that is the best that they can do, even though that's not the best procedure for the patient. But they also make a lot of money doing them. So unfortunately, there's a money motivating factor as well. And I'm seeing, let's say there should be 100,000 spinal cord stimulators put in a year, according to my criteria, where we can fix most people. and they're putting in about 500,000. So about 5 times too many spinal cord stimulators are going in. Spinal cord stimulators really are just like a pacemaker for pain. Look at that pinkish area right there. You see that right there? That is inflammation, and that's from the annular tear. Take it, and that's why this patient is having so much problems when they do have back pain, is from that inflammatory tissue.
We're not getting the endoscope feed in here.
You're not getting the endoscope feed. Okay, that's something we got to do, guys. It's like, I don't care. I know we're doing something a little different, but when you go poo-poo, you wipe your bottom with toilet paper. You don't go and not wipe your bottom sometimes. It's a sequence of events, okay? So brush your teeth. You do it exactly the same way every single time. You hook up an endoscopy tower, it should be done exactly the same way. You do endoscopic spine surgery, it should be exactly the same way. So you guys got to learn that there's nobody else that's going to come and do it for you.
We've got it now.
All right, good. Our patient sounds like he's very comfortable, and we've got our laser in here. We're inside the disc. We're waiting for you to turn the laser on. Carl, I think your mind has already set sail. So many things going on. It's so funny. No, my job is no big deal. I'm not really doing anything. But you guys have a really very difficult job, it sounds like. Okay. Anyway.
We have another question.
Sure.
We have a viewer who says, if I had the same surgery on my lower back, how long would it be before I could drive my car back to Tennessee?
You had the same surgery on your back, how long would it be? The next day, you could drive your car back to Tennessee. So somebody's saying, if I had the Deuk laser disc repair, when could I drive home? I live out of state. I live in Tennessee. You could do it the next day is what we would expect. Here's why. Number one, just take a look. Zach, show them how big the incision is. It's tiny. You're basically getting a tiny little cut on your back. But really the most important reason why you're able to drive home the next day is because we don't give you narcotics. See, you know about the opioid crisis, I'm sure, and it's a big national thing about painkillers and how they're overprescribed, and so there's really a push to get people off of painkillers. And one of the other advantages of this surgery we haven't even talked about is, laser off for a second, take this, is that this surgery is done without using narcotic painkillers. So the patients who have the surgery take Tylenol after the surgery. It's really quite amazing. So because you're going to be on Tylenol afterwards and not narcotics, you can drive. And, obviously, there's a 98% chance that that's going to happen that way, right? But there's always a chance of complications or something else going awry, which fortunately we haven't had that happen, but I would say there's a 98% chance you can drive back to Tennessee the next day. Now, the only thing is you're going to want to stop every 2 or 3 hours, get out, stretch your legs. But there's no reason. Dude, when you see me going with the laser, you turn that laser on. I'm not going to stop and talk to you. I'll tell you when I'm coming out with the laser. I'll say laser off or laser standby. But when I go back in, you got to be ready to just turn it on. All right. So yeah, answering the question, there should be no problem driving home to Tennessee the next day. That's what I would plan to expect to do. If you want to spend a few days here, you should, because I don't think you guys have a beach. Do they have a beach in Tennessee? I don't think Tennessee goes to the ocean, does it? Yeah. I've been to Tennessee. I don't want to sound ignorant. I've been there a couple of times, but they have a lot of lakes. And I went RVing in Tennessee one time with my family, and that was a lot of fun. Trying to remember if Tennessee had the highways that were really rough. I think they do. Huh? 55 North, right? A lot of potholes, and yeah, you guys got to get your highways fixed. Sorry. But honestly, it was beautiful. We had a great time. Went to a water park. Did some racing out there. So, lovely place to visit. Dr. Patel is saying Gatlinburg is really nice to visit. Dr. Patel's been to Gatlinburg. So what you're watching now at 12 o'clock in the endoscopy view is the laser. And Carl, honestly, this view looks a little blurry to me. I'm trying to figure out why. Right? I mean, it's not bad, but it's just not crystal clear like I like it. Maybe right there is the best we can do. All right. So 12 o'clock is essentially where the herniation base is going to be. So we're going to make our way over there. This is, remember when we put the dilator in like we already did, you actually jam part of the herniation back into the disc base, which is good because then it's going to be right here where we're working and it's easy to get out with little risk to the patient. So that's one of the advantages of this technique that I use as opposed to a, we call it the inside out technique where you start inside the disc and you work your way out as opposed to the outside in technique. And I only know of one surgeon that does the outside in technique, and he's in England, and his results are nowhere near as good as an inside out technique. The inside out technique is a technique of Dr. Anthony Young. Tony Young out of Phoenix. Dr. Young was one of my instructors when I learned how to do endoscopic spine surgery. I think we call him Master Yoda because he's truly a master of endoscopic surgery. But more importantly, he's a doctor who actually cares about people and their back pain and wants to fix it. And there's so many surgeons out there that don't believe back or neck pain can be fixed, so they won't even really try. And Dr. Young is a pioneer in endoscopic surgery, but also a pioneer in curing back pain. Now, he doesn't do neck surgery. He doesn't do neck surgery. Neck endoscopic cervical spine surgery it's a whole nother level. You know, if you think it's hard to master lumbar endoscopic surgery, which it is, mastering cervical is the highest level you can achieve. I suppose thoracic someday will be even higher, but it's not possible right now with the rib heads. I'm sure we could develop the instrumentation and make it possible, but the truth is there's just not a lot of symptomatic thoracic disc herniations. Plus you got your spinal cord there, so it makes it more challenging. So this is what we call a reverse herniation. You see how this guy's coming back out from the inside of the disc? He's just kind of working his way, but he's pretty scarred in there. Standby laser.
We have another question.
Yeah, of course. We'll take all the questions.
We have a viewer who's asking, is surgery always required to treat a bulging disc?
The question is surgery always required to treat what now?
A bulging disc.
Bulging discs. So, the answer is no. And there's two reasons that the answer is no. The first is that most bulging discs don't cause any problems for people. They don't cause pain. They don't cause nerve symptoms. They don't cause anything. No back pain, no nerve symptoms. So probably 95% of people with bulging discs have no symptoms. Or you want to zap around a little bit? Remember, do not get the laser fiber near the, go in, pull back a little bit. This is where you should be looking from, right here. Yeah, don't get that tip of that fiber inside the scope and push the button. Otherwise, you'll blast the lens right out. And then it'll be $5,000 to repair it. Yeah, when you see the laser go in, buddy, you got to just turn it on. All right, so you need to hold the pedal down, Dr. Patel. Don't go down in there. Stay more superficial. The reason that every bulging disc doesn't need surgery is, number one, as I said, 95% of bulging discs don't cause any symptoms at all. And then the 5% that do, some of them will get better without surgery using a shot or physiotherapy and letting the disc heal itself. So it would be accurate for me to say that 95% of human beings over the age of 40 have a bulging disc or more than one. And of those 95% of human beings over the age of 40 that have a bulging disc, only about 5% of them have pain or symptoms from the bulging disc. Of those 5%, about half of them will get better in their symptoms with conservative treatment like shots and therapy and just letting the disc heal. That's right. That's good, right up there. The other half end up needing surgery to fix the bulging disc symptoms. So I hope that answers your question. So just to summarize again, virtually 100% of human beings over the age of 40 have bulging discs somewhere. But of those people over the age of 40 that have a herniated disc or bulging disc, only about 5% of them are symptomatic and need treatment. Of those 5% of everyone basically that are symptomatic and need treatment, half of them are going to get better on their own. The other half end up needing surgery. So that's actually a really big number of people that actually need surgery. If you think about it, it's really close to 2% of the population that ends up having chronic back or neck pain that needs surgery for a bulging or herniated disc. I hope that answers your question. All right, Dr. Patel, let me get back in. Thank you. At this point, we're going to start moving the cannula, which is our working channel, further out. Okay, so you can see the end plate there of S1. The end plate of L5 is up there. This is the annular tear. A little bit of epidural bleeding. Yeah, you're going to switch it now?
Yes, sir.
All right, just thanks for letting me know. Tell me when it's done. Looks like it's done. Nice job, ladies. You done good. All right. So this is actually a pretty complicated surgery we're doing right now, and I'll tell you why. The herniation itself is a little bit medial, and you know what I tell people is there's no guarantee I'm going to be able to get it all with the surgery, because there's always going to be someone that I can't get all the herniation out or enough of it out. And the herniated disc, by the way, or disc bulge, whatever you want to call it, the disc bulge is a herniation, by the way. That herniation rarely, I mean, in 100 herniations that I've taken out, maybe one or two of them, the whole herniation will come out as one big piece. So most of the time, as a surgeon who takes herniated discs out, you're going to take it out what we call piecemeal. That's the term. And what it means is piece by piece. And the reason for that is that herniation's usually not one like big lump. It looks like a big lump on an MRI, but it's not. It's actually in pieces, fragments. And so a lot of times surgeons that do surgical procedures on people's spinal discs, like repairing a herniated disc, they'll tell you that it comes out in pieces, multiple pieces. If you look at your pathology report after surgery, you'll see the same thing. You're going to see multiple fragments of disc herniation, not just one. Zach, we got any questions?
Not yet.
All right. So what can we talk about? You know what we're missing is music. We need some music. Huh? Standby laser? YouTube? No, we have XM radio and we have. I don't understand. Am I missing something? Oh, U2. Gotta be faster. U2. Thank you. Yeah, U2 would be great if we can get some U2 on. Oh, there's a piece of herniation. Like I said, it's little fragments, so that's the thing. I'm just very, very happy that we're able to do this, to access the L5S1 transforaminal, because this guy's got a pretty high iliac crest, as you can see, and I feel very fortunate that we were able to get in so easily. I've told most of you all that we did have a patient a few weeks ago where we couldn't get in. Oh, there's a big piece right there. So I'm starting to tug on one of the herniation pieces. It's, yeah. Oh yeah. So nothing major, but little pieces, as I said earlier. That's really what the surgery becomes. You can see the pink right there. That's all inflammatory tissue, and that tells you we're getting closer to the outer annulus, right? Because you won't see inflammatory tissue in the center of the disc. There's no blood supply. So we're just getting these chunks out. These are all part of that big herniation he has on his MRI. The real question is, will we get enough? And we won't know until we've done more surgery if we're going to get enough of it out. I certainly hope so. I have to say I've been very lucky and not had a patient where I couldn't get enough out before. But, you know, there's always a first time for everything. Thank you for paying attention. So, again, we're just working on that annular tear and the herniation. And it's a process. It's never a quick in and out done. It's always, you know, there's so much scar tissue from the inflammation that's been going on by the time people come see me. Now, if you have a herniated disc that happens today and you come get the surgery tomorrow, there won't be all this scar tissue and inflammatory tissue. There may be a little bit of inflammation. But there won't be all the scarred down tissue. So when we play music, there's a volume button. You guys might have heard of it before, you might not have. I don't understand how the volume gets that loud. Is the janitor using the volume at night or something? Right, okay. Standby laser. How's our patient doing? He's doing good, good. Yeah. So these are all little pieces of that herniation. And again, unfortunately, it's going to come out in multiple pieces. Multiple is just means many. And honestly, I couldn't tell you how many it's going to take, but everyone's different with respect to that. So at this point, we've cleared that area out pretty good. I'm going to bring this back a little bit more. We're getting into the epidural zone. So we don't have a lot more that we can do in terms of pulling back, because we're already at the end of the annulus. So I've got to make all this count as much as possible. A little bit of fat there. Fortunately, the nerve roots are still more medial. Are you kidding me? Who's listening to this crap? Huh? This is Dr. Patel? His team listens to this nonsense? Really? I don't believe that. Or maybe his patients like it. I know that's a famous pop song. What's it called? Bubblicious or something like that? Burgalicious? Sorry, Bergie, Fergie, whatever your name is. Your music sucks. Yeah. Believe it or not, I got my own opinion about things. I'm not a sheep. Now, U2, that's good music. I don't think Bergie, Fergie, whatever her name is, will be coming to Duke Spine anytime soon to have their back fixed, and that's perfectly fine with me. So you can still see there's some herniation in there I want to get access to. I'm having trouble with the cable, not much. It's still pretty good, but I want to get right up to 12 o'clock. I need to get all the way up there. That's good, Luis. Thank you. All right, what other questions do we have? This is all the herniation right here, by the way, in case you're wondering. It's just stuck in there. So we're going to be here for a few minutes working it out. So we got time for answering some questions. You all see how it just disappears? I said U2, not Beach Boys. Can we put on U2, please? Have you ever heard of a group called U2? There's no station, I don't know. I think somebody suggested YouTube or something maybe. All right, there's that herniation right there. So I'm going to take laser off.
We have a question.
Watch your shoes. Oh, yeah. Yeah. We're not going to listen to 1940s. What do you got? Magic Dragons? Oh, Imagine Dragons? What happened to good old U2? Huh?
We have a question.
All right, why don't you put on, what are we Sirius? Sirius XM? Put on Hair Nation then. Hair Nation. I'm not going to listen to like 1940s music. Yes, we'll take the question. Dude, laser's on. It's all right. Yes, take the question.
So we have a viewer who says, after you debride the disc at the tear and it heals, what about the nerve pain? What makes that better?
What makes the nerve pain better? Great question. So, what makes the nerve pain come is inflammation. So you got this herniation, right? And that herniation is sitting in the annulus. And the annulus has a blood supply. So the annular blood supply sees the herniation and says, oh my gosh, that's not supposed to be here. Let's get rid of this. So your annular blood supply basically sets out on a crusade or a mission to get rid of that nucleus pulposus that we're zapping away right now with this laser. So your blood supply within the annulus, it has a job to do. And its job is quite literally to start an inflammatory response from the herniated disc. So it actually starts an inflammatory response and tries to get rid of the herniation. You understand? And That's what causes the nerve pain, is that inflammation right on the nerve root, right here where we're working, from that herniation right there. That's the herniation. I'm just digging right into it with the laser. I'm just zapping it away.
The fibers you see, that's annulus or PLR?
That's a higher level. I can't answer that, Dr. Patel. I'd have to kill you. This is the herniation.
No,
Yeah,
the
I know,
fiber,
I know, I know, I know.
the white.
I gotta be careful how much I teach you, because we have John Stewart and Phil recruiting people from our business out to Orlando for their surgery center, and I don't know who's gonna go next. Honestly, I don't. And I, you know, unfortunate.
Yeah, but be careful.
Oh, I hope he's not going there. Those guys are lying, as I told John before, a lying sack of you know what, manure. That's what John Stewart is. Do not trust that man. Anyway, laser off. Those are, what you're seeing is the oh good, put that volume up please. What you're seeing is the fat, right, the gold stuff. And then right up here at 12 o'clock is the epidural space. And right here is the herniation. I mean, it's part of it. We've been working on the herniation for a while. But that's the epidural space right there. You understand? So you're actually looking past the posterior ligament, because this is a pretty big extrusion, right? It went past the posterior ligament. And so we're literally, I'm going in and sweeping. Oh yeah, getting, you know, pieces of the herniation out. I knew it would be difficult. It wouldn't come out in one piece. I didn't expect it to. So I'm just going to keep working on it. You see it down there? Did I answer all the questions? It's pretty wet down here. We're probably going to need a towel on the floor. Zach, we have any other questions?
We just go on actually. We have a viewer who is asking, does decreasing or accelerating the suction affect the quality of the image from the camera?
Oh, so does altering the suction affect the quality of image from the camera? Yes, it sure does. That's a great question. Watch. Here's on full suction right now. And usually it sucks bubbles. But what I do is I usually work with it off. It also is noisy. But normally it does. Yeah, it has a pretty good effect on the quality of the image. Alright, so to get more medial, I'm going to have to manipulate the tube and try to get a little bit more medial. So we're kind of limited in what we can do, because we're going to have a nerve root just outside of that tube at 12 o'clock. There's going to be what's called the traversing nerve root. And since we're at L5S1, it would be the S1 nerve root. But what's causing the image to be so ugly right now is not suction. It's actually, it's the debris and the blood. There is actually blood in here. There's little bleeding. You see it right up here? You guys see that? Those are little epidural veins. They're actually releasing blood. And that's why the image quality is not stupendous, because that blood is clouding the water and making it hard for you all to see what I'm doing. But I see the same thing you see, by the way. The difference is I've seen it many, many, many more times. So I know what to do even when the view gets bad. It's kind of like driving in the rain, you know. The more experience you have driving in the rain, not seeing as well, the better you're going to be at driving in the rain. This is all still that same herniation. and it's so scarred down. And that scar tissue comes from just waiting, you know, not getting it fixed sooner, which I recommend people wait about maybe 2 months from the onset to get it fixed. And if it's not back to really, really good levels of pain by 2 months, then you're going to need surgery. Just get it done. Don't put it off. The longer you put it off, the more scar tissue that forms, and the harder it is to fix.
We have a question.
Yes.
We have a viewer who says, I have 2 herniated discs in my back that are causing me to have weakness in my left leg. I was told I need a fusion. Would this surgery be a possible alternative?
Yeah, so somebody is saying, I have 2 herniated discs in my back. I have weakness in my legs. I was told I needed a fusion. A fusion, if it's done properly, so just the word fuse means to fuse 2 bones together. A fusion by itself will not work. What you need is a decompression and possibly a fusion. That's what your surgeon, I hope, is telling you. Make sure they're going to do a decompression, though, because it's the decompression that gets rid of the leg pain. But yes, to answer your question, this surgery would replace the fusion and decompression. We do a decompression with this surgery as well, which is what we're doing right now. And you don't have to have a fusion. So the Deuk laser disc repair would be a much better option than a fusion with a decompression. Now I'm going to tell you, there's probably about maybe 4 or 5% of patients that will come here for laser, or we'll talk to them over the internet after reviewing the MRI, and they're not a good candidate for the laser surgery. About 5% of the people that contact us, okay? So I would have to look at your films and tell you for sure whether we could do a different, the laser surgery instead of the fusion. So when I say that, yes, it should work, that's just based on probabilities. Standby laser? In other words, I wouldn't know until I see your film and I maybe do an exam over the internet of you to look and see, just what things look like on your MRI. Because there's always going to be situations where I can't fix somebody's problem with a laser, but with this surgery you're watching now, but I have to say it's pretty rare that would be the case. There's the big herniation, guys, right there. We got it. We got it. That's it. Take a look at that thing. Can you see this, Zach? With the camera? No, the white is going to... You see it? That's it. It's by Luis's hand now.
Something in the way. Hold on one second.
Here's another little piece.
Yep, we can see it.
Yeah, so we've been taking out most of it, but this is like a big chunk. This is what we as surgeons really hope for, because it just, anytime you can do a surgery faster for the patient, less anesthesia, it's always better. So, getting a big piece like that out speeds things up, and it just think it's better for the patient overall, just to... So the questions have been really good so far. Let me see if there's any more I can get. I'll probably get a little bit more with the laser. And then we'll be done. I'd say 5 minutes and we're done. I mean, look at the pulsations right now. Look at that pulsing. You see that? Did you guys see that before? You didn't see it before. Because now the herniation's gone and you're starting to get better venous pulsation. That's one of the signs we look for.
We have another question.
Yeah.
We have a viewer who's asking, how did you get the idea of using the laser for this surgery?
How did I get the idea of using laser? I was taught it. for the surgery. So, just for those of you interested in knowing, I was trained with traditional spine surgery. Your fusions, your microdiscectomies. We did a little bit of endoscopic surgery, but I was trained at probably the best training center in the United States of America for spine surgery. There's probably two places. Wipe it, please. Okay. One was the Barrow Neurological Institute, and the other was the University of Florida in Gainesville. And what made these two centers so exceptional when I was training was really the faculty, the surgeons that were there. Basically, they were really, really good spine surgeons, and I had the ability to train under them and learn all the the most advanced spine surgical techniques in the world: decompressions, reconstructions, trauma, corpectomies. I mean, anything you can think of in spine, we did, and we did it really, really, really well. So I came out of my residency of 7 years of doing spine surgery with some of the best spine surgeons in the country. Thanks. And laser was something that we only used for pediatrics. Oh, it's so foggy. And the reason was we would do a procedure in kids because their spines are so small, where we would need to use the laser because the metal instruments were just too big and they didn't do the job well. So my first experience with the laser was during residency, where we used the laser in pediatric spine surgery at University of Florida in Gainesville. Can we get some of the older U2 on? This newer album of theirs is not as good. But anyway, then after training, I went out and started practicing on my own in 2004. And I met a rep, basically, for, I would do these surgeries for trigeminal neuralgia at the hospital. And I met a rep there who asked me during surgery, he said, "I see you do a lot of spine surgery." I said, "Yeah." He said, "Would you like to learn how to do these endoscopic laser procedure?" And I said, "Yes, I would." I said, first of all, "Does it work?" And he said, "Yeah." And I said, "Where do I have to go to learn it?" He said, "It's local." Not local like in my county, but in Florida. And so I said, "Sure, I'm open to learn new things." So I went and I studied with an orthopedic surgeon who was doing some of the endoscopic surgeries. And I saw the procedure in action, and I was just amazed because it was something. He was an orthopedic surgeon, and as a neurosurgeon, orthopedics are a little different, but orthopedic surgeons are very used to what's called arthroscopic surgery, which is basically surgery through a scope. Now, neurosurgeons, we don't do a lot of arthroscopic surgery. At least back in 1997 to 2004, when I did my training, neurosurgeons didn't really do arthroscopic surgery. We didn't do any arthroscopic surgery. We did endoscopic brain surgery. We did endoscopic pituitary surgery. We did endoscopic shunt surgery, but that was it. Nobody did endoscopic disc surgery. So the whole concept of endoscopic cameras, towers, all that stuff was very foreign to me as a neurosurgeon. And when I saw it in action, I thought it was really cool. Of course, I did some endoscopic stuff in general surgery when I was a resident. So, gallbladders and colectomies, and when I did OB-GYN, I saw some endoscopic female surgeries. But the fact is that neurosurgeons really are not trained on much endoscopic surgery, at least back in the day. So having the opportunity to work with an orthopedic spine surgeon who did shoulder scopes and knee scopes as well, but also did spine scopes, it was really an exciting thing for me, and I saw tremendous possibilities because of the minimally invasive nature. And the approach being transforaminal, you don't have to remove bone. So I wanted to learn more, so then I went to whoever taught him, which was Dr. Anthony Young. And then I went overseas and I trained with the Koreans, who were doing the most endoscopic spine surgery of anyone in the world, and German physician, Dr. Reuten, and I think a Chinese doctor as well, Dr. Chu. So I just did a lot of training. I invested a lot of my time and money traveling and learning from the best in the world. And then I came back and I just started playing with different, manipulating or changing what was being done, and found better ways to do it. And pretty soon, after about a year or so, my results were far better than any of the other surgeons that I trained under. And I was doing things different, and I was having better results. And so I developed my own procedure, and then we published it. And that's what we do now. This is really the last of the herniation up at the ceiling here. I think we've gotten about 80% of it. I think our patient's going to be real happy, I hope, with the results. We won't know until they wake up. But hopefully we'll show you this patient shortly. Standby laser. How much energy have we delivered?
So far, 38,000.
38. So that's a pretty good dose. Virtually all of our discs are in the 30s. So 38 is pretty par for the course. Yep, I'm trying to get, if I can get any more of that herniation out, that's what I'm trying to do right now. And that's better.
We have a question for Carl, actually.
Okay, Carl.
We have a viewer asking, on the trip, do you have to check into customs if you go to other countries?
Hold on. He's saying yes, he has to check into customs when he goes to other countries. You want to expound on that, Carl, or is that just a yes answer? You have to take the crew list? Photo documentation? Passports? He's saying yes, he has to. Sometimes they come out on a boat and check out your boat, right? They fog your boat for mosquitoes. Interesting. They don't want you bringing any mosquitoes in. Huh? Malaria, yeah. So yes, he said he has to check in with customs everywhere, and that sometimes they have to get strip searched, and that's his favorite part. And even sometimes there's a full body cavity search as well. And that's why he always goes prepared. But no, it sounds like he's going to have a wonderful time with malaria, mosquitoes, Zika. Don't have any babies anytime soon. So are you, that's weird. Say 2 more minutes maybe. I'm just about done. And standby laser. By the way, of the type of surgeries that we do endoscopically in the lumbar spine, this is absolutely the hardest, just so you know. L5S1 with a central paracentral herniation. It doesn't get any harder than this. This is not a beginner level endoscopic surgery. So I think we're just about done. I'm just trying to get as much of this as I can, and it looks like most of it's just scar tissue. I'm feeling some bone spur. Stand by, laser. I think we could use the laser just to get a little bit more. A lot of pulsing going on now, you can see it. But I've gotten as medial as I can at L5S1. And that's the hard part. It's easy to get lateral at L5S1, and once you get in, getting medial is almost impossible. And of course we have the bleeding on top of it, which takes away from your view. I'm not complaining, I'm just kind of sharing the experience from what I'm seeing and what makes it so difficult. Just want to get this last corner here. And yeah, the reason why you're all having trouble seeing is the bleeding. And it's not a lot of bleeding, it's just enough to, remember the whole width of this tube is 6 millimeters, so we're not talking about a lot of bleeding here, we're just talking about enough to challenge the surgeon. Certainly not a problem for the patient. So we've had some really good questions today. I'm going to head over to the conference room in a few minutes and I'm going to answer additional questions that the audience might have about the surgery in just a minute. I just want to, again, get as much out as we can. I think we've gotten probably 90%. There's still a little bit left that I'm not going to be able to get to. And really the question is that going to be a problem or not for the patient? So the only way to know is with time. Time will tell us. We'll see probably in about an hour when he wakes up, we'll know if the procedure was successful, which I expect it will be. But we'll know in about an hour. Yeah. You see, Dr. Patel, we've done pretty much everything we can. I can't get more medial. I'm as medial as I can get. I can feel we're close to the nerve. I think there's just a little bit left. Now, once you're done, this is a nice song. Once you're done with this, you basically, there's a hole here, right? And that hole has to heal up. Stand by, laser. And that's the patient's job, is to let it heal properly. And the things that the patient can do to heal this properly are going to be good nutrition and really avoid any kind of heavy lifting until this is healed up. It usually takes 6 weeks to 3 months to completely heal. The disc will be at 100% strength 1 year after surgery. So I always encourage my patients to take it easy for the first year. That's just bone spur. Yeah, you can hear it snapping on the bone at the back of the end plate. Hold. I think we're done. I don't see anything more. We're up underneath the fecal sac now. I could just try for a smidgen up there, but I feel really good about this. I'd say 2 minutes. More volume. More volume.
We have a question.
More volume. Yeah. That's better. Yes, I'll take the question.
We have a viewer asking, do the patients need to be on any antibiotics for this surgery?
Yeah, we give 1 dose of antibiotics prior to skin incision, which is the generally accepted protocol, preoperative antibiotics, within an hour of incision. And after that, we're done. No, there's no more antibiotics that they get. Luis, give me the full cable. All right. Laser off. That's the only antibiotics they get before surgery. There's no antibiotics after. We're done, folks. There was no metal, no fusion, no artificial disc. Scope off. Medicine. Oh. You ready? All right, we're coming out with the tube a little bit lower, right there. Come on, grab it. All right, a little pressure on the paraspinous muscle, and Dr. Patel will show you the incision. I'm going to head over to the conference room, and we'll have some more question answer time. Right behind you, if you don't mind. Thank you. Nice job, ladies. So this was the right DLDR L5S1, and we have he had a concordant pain, right? So the assistant would be Dr. Patel, MD. Complications, none. Our blood loss was, I'd say, maybe 3 mils. And discogram was concordant. Perfect. Thank you. Is there anything else you need me to sign? Blue tabs.
We can add to the op note, or do you like to do it?
No, that's good. Just the assistant's name, Dr. Patel. Or if Dr. Patel's not here, it would be Luis or Carl. Thank you, ladies. Great job. All right, I'll head over there, Zach, and we'll take some more questions. Thank you, everybody. Great job. Okay, I'm here, Dr. Deuk with Zach, and just so that everybody understands that watches these videos, these are live spine surgeries. We broadcast them literally around the world, so they're available for free, no charge to anyone, thanks to the Deuk Spine Foundation for research and education in spine. And the Deuk Spine Foundation provided the audiovisual equipment we use to be able to do the broadcast, nothing else. But point number one, if you have extra change and you want to donate, the Deuk Spine Foundation's still around. We really do need donations. We don't have the money to continue to do any kind of programming that's new because funds are low. So if you have the ability to donate, look up the Deuk Spine Foundation. We are 501c3. This is a nonprofit registered with the IRS. All right. I'm gonna because these are live surgeries, they're broadcasted. That makes them very special because we're the only spine surgery facility in the world that broadcasts live spine surgery. We broadcast live spine surgery every surgery we do. That's every week, unless I'm on vacation or at a meeting. So every single spine surgery is broadcasted. So here are the things that Deuk Spine Institute does that no one else in the world does, and we're the first to do it. Number one, we broadcast live spine surgery. Number two, we broadcast every single spine surgery live. Number three, we don't charge any money for admission. It's free to the public, to anyone who wants to watch. Number four, we broadcast in high definition. Number five, we broadcast endoscopically, which nobody else does. Number six, we broadcast microscopically, nobody else does. Next, we broadcast first-person surgeon view, which is with the camera mounted to my head when we do spinal fusion surgery, which we did not do today. But we broadcast first-person surgeon view. We're the first in the world to do it, the only one in the world to do it at this time, and we've been doing it now for 4 years, by the way. We also broadcast third-person view live in high definition. So, and we're able to integrate, obviously, audio and endoscopic, microscopic, fluoroscopic views along with live feeds of first and third person view. So, it's really, honestly, the most sophisticated audiovisual spine surgery experience you're going to find in the world in 2019, 18, 17, 16, even 15. So we're not bragging, we're just saying that we're the first to do that. That, we're in a very unique position. We also have many firsts with surgery. We're the first outpatient surgery center in the world to do a posterior cervical laminectomy and fusion with instrumentation. Literally the first. And we've done now almost 50 or 60 of them in the last 4 or 5 years. So we've got it down. People go home literally within 2 to 3 hours of the surgery. We're also the first surgery center in the world to ever perform a 2-level transforaminal lumbar interbody fusion, open with osteotomies and reconstruction. We're the first in the world to do 3-level, first in the world to do 4-level, first in the world to do 5-level. Also the first in the world to take an intradural tumor out off the spinal cord in the lumbar spine, and that was the very first surgery we ever did. That was back in 2014. So, I could keep going on and on and on with the firsts. But why are we the first? Because we are the pioneers. We're the tip of the spear, the tip of the arrow. And we do first all the time. It's second nature now to us. We don't even talk about it really anymore. We just do it. And we do it because we can, because it's the right thing for the patient, and it's the right thing for medicine. So I'm going to talk about one more thing since I have your attention for the time being, and that is, let's talk about something called honesty and integrity. One of the things that bothers me about modern day medicine, and this has been probably for the last 20 years, is the amount of dishonest people in medicine and healthcare, and the amount of, or lack of integrity these people have. And, I'm not just talking about anything to do with the broadcast. I'm talking about in general in medicine. Administrators of hospitals, doctors, chiropractors, therapists, nurses, you name it. There's so much dishonesty, and it bothers me. It bothers me because I went into medicine with my father as a role model, who was an incredibly honest man and always put the patient first, their needs first. Never, I mean, literally got 4 hours of sleep a day because he was always at the hospital. He was an OB-GYN, so he was constantly going and delivering babies. He loved it, you know, but, you know, he was always honest with his patients about everything. Even if there was a problem, he'd just tell them, look, there's this problem. And they would discuss it and come up with a plan together. That's how I conduct myself, not just with my patients, but with everyone. I'm honest with my staff. I'm honest with my patients. I'm honest with the hospital administrators. And I'll be honest with you. Sometimes people don't like the honesty, and that's okay. Don't watch my videos if you're offended by people who are honest, because this is not the right place for you. I'm not going to sugarcoat anything. I'm still polite and respectful, but I'm not going to lie to you. I'm not going to sugarcoat anything. I'm just going to lay it out as it is. Now, something you should know about me as an individual, Dr. Arajik. I'm not trying to brag to you, but I will not talk about a subject that I don't really thoroughly understand and know. And some of the things you're going to hear me talk about are things that you're going to hear for the very first time and go, wow, that's a strong opinion. How could you say that? I say it because I understand the issues. I've spent a lot of time understanding them. And you're not listening to some dum-dum here. You're listening to a neurosurgeon. Now, there are some dumb neurosurgeons, okay, I'll give you that. But you're not just listening to a neurosurgeon, you're listening to, during my residency time, I was the top pick in the country in neurosurgery coming out of medical school because I was the valedictorian in my medical school, and also a researcher who had significant research done in neurosurgery and neurosciences, and also a tremendous amount of extracurricular activity and leadership. So when I'm telling you, when I give you my opinions, you know, you may not agree with them, and that's fine. I'm not asking everybody to agree with them. I'm sharing my opinions about things, but I want you to understand these are opinions that I don't just say, you know, without really detailed information. I'm not going to talk to you about politics. I'm not going to talk to you about aneurysm surgery, because those are areas that I'm not the latest expert on, okay? But what I do know a lot about is the healthcare administration. I know a lot about insurance in healthcare. I know a lot about spine surgery. I know a lot about back pain and neck pain. And I know a lot about coral diseases, okay? So those are the things that I will talk about, and I'll give you when I talk about them, I'm going to give you my opinion, and understand I'm giving you my opinion because I believe my opinion is correct, and that's based on tremendous amount of research and information. So you don't have to agree with my opinion. That's perfectly fine. My mission in life is not to get everybody that listens to these broadcasts to agree with me. It's just not. My mission in life is to share what I know is fact with you. And the people who say, oh, I don't agree, that's fine. You're welcome to stay and watch and ask questions, and I'm not offended in any way, trust me. But you will find out what I say is fact eventually. And the sooner you figure that out, the better for you. Because then you can take what I'm teaching you and apply it to your life and try to make things better. Another thing is, I will never fix every one of the problems in the world. I want to. I have ideas about how to, but I can't do it alone. So it really requires people like you, the people listening to this broadcast, the people listening to this recording. It requires you to help implement changes. I can guide you. I can tell you what the problems are. I can even give you a suggestion about how do we fix it. My ideas about how to fix problems aren't necessarily going to be the best, but they're an idea. They're a movement in the right direction. And maybe they need to be refined, and that's fine. But in the end, change cannot come about from one person alone. Change requires many people to adopt an ideology and develop a strategy for bringing about positive change. Positive change is change that helps people, okay? I'm not talking about change that helps the insurance companies make more money. I'm not talking about change that helps bankers get richer. I'm not talking about change that makes implant company manufacturers richer. I'm talking about change that helps human beings live a less painful life and a better quality of life. That's what everything I do is geared towards, is helping people get better. That's because I went into medicine, I believe, for the right reasons, which is to help people. And that being said, There are going to be people who say, well, why do you charge your patients money for surgery? Well, because I can't pay my staff and pay the bills without it. Sorry, we're not a charity. Deuk Spine Foundation is a charity, but it doesn't pay for any of the bills. It only pays for the broadcast, basically, that we're doing. So there's a lot of people that donate and volunteer their time to the foundation as well, including myself, which is all uncompensated. All right, now I'm ready for the questions. Should the laser be combined with an aqueous solution to be effective? The answer, huh?
That's actually our second question. There's one up on the screen already.
I apologize. Zach has typed up the question, so I'm going to go to the first question. I apologize. I'll get to that next. You often ask your team about the energy that's been spent in joules. What does that tell you? Well, great question. So this herniation that we're working on, I'm using laser energy to remove it, and I want to know, is this particular disc that I'm using the laser on, is it like an anomaly? You know, sometimes I get the feeling that I've been zapping it for a long, long, long time, and so great question, but what the joules tells me is how much work I've really done. You like that? So if you're an engineer, you understand what I just said, because joules is a measure of electrical or energy work basically, energy and time, and that is the definition of work. And so, yeah, it's just for me a gauge of, like, you know, is this normal? Am I still within the standard deviations of being normal for this disc? Because sometimes I get talking, I get distracted, I'm doing something else. So it's like a waypoint. It tells me that I'm still on track and everything's still good. It's as a neurosurgeon, I use a lot of different things to assess the situation. I don't rely on one thing, and I think that's for life in general. You never want to rely on one piece of information or one stream of information. You want to be taking in many streams of information at the same time and assessing each stream, and that gives you an idea of where you are relative to where you expect to be. So that's all it is. Next question, should the laser be combined with an aqueous solution to be effective? The answer is 100% yes. Without water around the tip of the laser and around the tissue, that irrigation, then things can get dangerous. So what could be dangerous? Well, the liquid around the tip of the laser controls how far from the laser fiber tip the laser beam travels with energy. So what that means is, if you're shooting a laser in a pocket of air, you don't know how far that laser energy is going to go before it dissipates and it becomes harmless. So in aqueous solution, basically the pulse of energy coming off the tip of the fiber only travels 0.5 millimeter to a target and then releases the energy. So by having an aqueous solution on the tip of the laser, I can make sure that, you know, Star Wars fight scene with laser weapons isn't happening inside the patient's body. In other words, I can make sure the energy is being controlled and it's only being directed at 0.5 millimeter from the tip. So that's one thing. The second is the aqueous solution helps to remove the blasted tissue, for lack of a better description. Basically, I'm blasting away with the laser the herniation. It's coming out in little pieces, like the laser energy is transferred to the tissue gets disrupted. What that means, imagine like an explosion with a lot of little pieces of tissue that come off. And so the aqueous solution removes those from the surface of the herniation. So it basically clears the rubble, so to speak. By clearing the rubble, then you can see where the next blast goes. The other thing the aqueous solution does is it's cold, refrigerated, so it actually keeps the tissues cool and keeps them from burning. And so rather than burning and smoking, they just come off nicely, and, you know, I think that's important too. So the aqueous solution cools the laser tip, cools the target, and it removes the debris, and it keeps control of the energy pulse so it doesn't get too far away from the laser tip. So those are the reasons. Next question, what kind of laser do you use for these surgeries? So we use a medical laser, obviously, but more specifically, I use a holmium YAG laser, YAG. That stands for yttrium, argon, and garnet. So YAG is yttrium, argon, garnet laser. YAG, holmium YAG. And the manufacturer, I can't remember. I think it's Luminous. But basically the best laser in the world is what I use, if you want to summarize it. There's other types of lasers, like CO2 lasers, that are dangerous, and there's potassium lasers. There's a lot of different kinds of lasers, probably about 5 or 6 that are used in medicine, but the holmium YAG laser is the best in the world. It's also the most expensive. So.
Okay. So it's asking, if the discs aren't able to regenerate themselves, how are they able to heal, and would a tear be considered closed after a few weeks?
So, by the way, great questions today. I appreciate all these questions, really, really insightful questions. So it indicates that either my audience is coming back and watching multiple surgeries and learning from what I'm teaching. That's what I'm seeing with these questions. Or we're getting an audience that is just coming more educated, AKA in the healthcare field, or just doing a lot of research. So, yep, I appreciate it. I truly believe that a patient who knows as much as I do is going to make the same choices that I make for them. And that's what I wish every one of my patients was. I wish every single patient that came to me knew everything I knew without exception. Like, knew all the details, good and bad. Because I'm sure they would make the same decision as me, because I always try to make the right decision for the patient. So to answer your question, if the discs aren't able to regenerate themselves, so let's take that first. What is a spinal disc? It's really, truly 3 things, but we don't really count the 3rd thing. But so the spinal disc is in the center. About 80% of the volume is a jelly called the nucleus pulposus. Okay? And I've talked about this in past videos. The nucleus pulposus is in the adult, which is, once you're out of the womb and you're a baby, really it starts there. The nucleus pulposus is the center of the disc. It's jelly. And what it used to be embryologically was the notochord. That's Notochord. The notochord, while you're an embryo, very early on in the first trimester, is an incredibly important tissue that directs the development of the entire fetus. It's the thing. It is like the director. And once you're born, it's like done its job. It's retired. It retires. And literally, the notochord breaks up into segments and becomes your spinal disc, the center of the spinal disc, called the nucleus pulposus, all right? So the nucleus pulposus is this really weird tissue, mostly water, full of proteoglycans and a few cells. But it used to be the notochord when you're an embryo, very important, but now as an adult, it's basically a shock absorber. All right. So that's your nucleus, 80% center of the disc. Now there's a rind or a containment system, basically a very dense fibrous tissue called the annulus fibrosus. Fibrosis in Latin means fibrous or tough. So the annulus means ring, in Latin. So the annulus fibrosus is a ring of tough tissue that holds the nucleus pulposus jelly inside the middle of the disc. Now the annulus is what gets damaged or torn with trauma, like too much bending, twisting, lifting, whatever, car accident, fall, sports injury, football, gymnastics, golf, you name it, you tear the annulus. The annulus is that, if you ever eat steak, it's that really thick rind of chewy stuff that goes around the meat, and you always cut it off. Nobody eats it except John Candy. And if you think about the annulus, it's this tough fibrous tissue that holds the nucleus in the center of the disc. When that annulus tears through and through, that means from the inside to the outside, there's about 25 layers of collagen in there, crisscrossing. When that tears through and through, and you lift something, your pressure on that disc is going to push the jelly, the nucleus in the center, out through the path of least resistance, which is going to be that tear. When the nucleus pulposus squeezes through the tear, either a lot of it, little bit of it, doesn't matter. If it's a lot, it's an extrusion. If it's a little bit, it's a bulge. Point is, once it starts wiggling its little head out through that tear, it's called a herniation, right? Herniation, think about your intestines herniating through your abdominal wall. They're herniating through. So it's a tissue contained within a wall that there's a defect in the wall and the tissue starts coming through the defect. So the defect in the wall and the disc is your annular tear. And what comes out is not your intestine, but your nucleus pulposus. So that's why it's called a herniation. Anyway, long story short, your first question says, how come discs can't regenerate themselves? And the answer is the nucleus pulposus that's in there was given to you as embryonal tissue. It's made in the embryo. It stops being made in the embryo. It's transferred to the adult, so it can't regenerate itself. It doesn't have stem cells to regenerate itself. It doesn't have the capacity to regenerate itself, okay? The annulus fibrosus can't regenerate more annulus either, but the annulus can actually heal, and when you have a tear in the annulus, the annular tear edges can come back together because remember, they have a blood supply in the outer half. So they can do inflammation and then healing with collagen, scar tissue, which is what they are anyway. So you're able to heal your annulus, but you can't heal your nucleus and regenerate it. And there's no regenerating the annulus. You can't make more of it. It can just heal. So how are they able to heal? If discs aren't able to regenerate themselves, how are they able to heal? So the way the annulus heals is the way that your skin heals. The way that any injury to your body will heal, it's with scar tissue. Okay, and the scar tissue comes from fibroblasts and macrophages that are circulating in your bloodstream, that come from your bone marrow basically and other sites, but they get into your bloodstream, circulate around, and when they see an area of your body where there's a breakdown of your blood vessels and there's leakiness and all these inflammatory mediators are in that area, they'll go there and they'll literally crawl out of your bloodstream and go into your disc, and they're gonna start to work to heal your annulus. And what I mean by that phrase is they're gonna form scar tissue. They lay down collagen, elastin, fibrin, and they literally seal off that annular tear. Okay, so how are you just able to heal? With a little bit of help from your inflammatory system. That's how they heal, from all the inflammatory cells. Okay. And would the tear be considered closed after a few weeks? So, yes, it'll be closed after a few weeks, but it'll be a very weakly held together closure, okay? So, it will be closed after a few weeks, but it'll be easy to re-injure it and tear it back open. So if you want that annulus to be healed solid, you got to give it a full year. Great question. That was our last question. I guess you're all tired of hearing me ramble on. Anyway, I'm Dr. Odigmajan. I'm sitting here with Zach, and Zach and I are going to go have some lunch since you all don't have any more questions for us. Hope you have a wonderful day. And by the way, our patient should be ready to go soon, probably in the next 10 minutes. So, a couple of things. Number one, be ready for a live stream in about probably 15 minutes if our patient's ready to go home, and we'll see how he's doing. Number two, tomorrow morning, 9 a.m., we're going to do something very special. We're adding on another surgery. This is a patient from Canada who had a spinal fusion done, spinal surgery done by a neurosurgeon in Canada who, for some reason, was arrested and I guess in jail. But that's besides the point. They then had a spinal cord stimulator placed by another doctor in Canada, and she comes to Florida, I guess, to vacation with her husband, and starts getting weakness in her legs with some pain where the stimulator lead is, and she comes to me and says, why am I getting weak? Something's going on. We got a CAT scan. She's got a hematoma behind the leads, and it's pushing the leads against her spinal cord. She's going paralyzed. So we just got permission and authorization from her insurance company to move forward with surgery on an urgent to emergent basis. And so we're going to be doing a thoracic laminectomy and evacuation of intraspinal mass, decompression of the spinal cord, prevent her from going paralyzed, probably remove her paddle leads, and laminectomy, fusion, and then remove the generator. So that's tomorrow morning, 9 a.m. We're adding it on because it's an urgent emergent surgery, and we just got authorization. So that should be an interesting case to watch if you're around and have time. Otherwise, toodaloo, cheerio, carry on, enjoy your day.